Welcome to audio file number 2. I'm going to start off with the section titled Infection. Infection occurs when a microorganism, like a virus, a bacteria, parasite, viroid, fungus, prion, or something like that, passes to a host, then invades, colonizes, and multiplies. The transmission occurs via carrier. So people already infected with the agent would be the carriers spreading it to someone else. They're going to transmit that from some way like water, food, airborne inhalation, could be a vector transmission if it's a mosquito, something like that. Now, immunity normally produces an adequate response to repel some sort of an invading agent by producing antibodies. If, in spite of this, the host contracts the disease, it could be because the defenses were weakened by deficiencies in their immune factors. Alternatively, if a microorganism's inherent properties might overwhelm a host's defenses through some sort of cell destruction or toxin. The infection includes the interplay and imbalance between a microorganism and the host. The virulence factor of the pathogen relates to its characteristics of bacteria-mediated pathogenesis. Some bacteria produce toxins that damage cells and have protective coatings that prevent the phagocytosis by the body's defenses, and others have proteins that allow them to adhere to the cells of the host, often entering a cell, which would result in cell damage or destruction. Once inside a cell, the bacteria is often safe from antibodies, and the host produces those antibodies to fight off the bacterial invasion. So if it's hidden, they can't do anything. The host-mediated pathogenesis is related to the immune response in reaction to a bacterial infection. This immune response may cause as much or more damage than the bacteria. In response to some bacteria, the immune system, including lymphocytes, macrophages, and neutrophils, may release toxic factors that could cause so much damage to cells that it allows for the proliferation of resistant bacteria. And in other cases, the lack of a cellular response to some bacteria would just plain allow them to multiply rapidly. Now, infection occurs when a pathogenic microorganism invades a host of a different species and then multiplies within that tissue or on the body surface, resulting in some sort of a damage or a disease. So some examples of infections are going to be airborne infection. This would be like inhaling a pathogenic microorganism in something like a dust particle into your respiratory system. It could be a droplet or aerosol infection, which would result from the inhalation into the respiratory system of pathogenic microorganisms carried in droplets that have been exhaled by others who already were infected, like when somebody coughs. There could be an endogenous infection, which would result from dormant pathogenic microorganisms that are reactivating within the host's body. This is what we would see with tuberculosis that I work with on a daily basis. So if someone had latent TB and then it became reactivated, that's how you would have that endogenous infection. There's also subcutaneous or tunnel infections that would result from invasion by a pathogenic microorganism of the subcutaneous tissue of an artificial opening. You see this with stomas a lot. And then there is opportunistic infections. They would result from pathogenic microorganisms that usually cause no infection, but they have overgrown or invaded the tissue in response to suppression of the immune system. We see that sometimes with chemotherapy or antibiotics. And so you could also have autoimmune disorders like AIDS, HIV, that could help an opportunistic infection to take hold. There's also bacterial infections that we worry about, and different types of bacterial infections would include subclinical. Subclinical causes no obvious symptoms. It's kind of, it's called subclinical because it doesn't show any outward signs. We have latent, that would occur when people have no symptoms of an infection, but they are carrying something that could cause an infection. Accidental bacterial infection occurs outside of the normal transmission modes, and these would be from something like a needle stick or an act of aggression or terrorism. You have opportunistic bacterial infections. These are going to be from when normal flora would overgrow, usually due to immunosuppression. Primary bacterial infections. Those are going to show clinical symptoms. A secondary bacterial infection follows a primary infection, but it's noticed because of it's separate because of a host compromised. A host compromise. So secondary bacterial infection would follow that primary infection. Mixed bacterial infection occur when more than one pathogen is causing the symptoms. An acute bacterial infection presents rapidly with obvious symptoms that may persist for days or weeks. A chronic bacterial infection persists for long periods of time, months or years sometimes. A localized bacterial infection would remain in a circumscribed area, so within one particular region or area. A systemic bacterial infection would be more generalized. It might cover different areas of the body and is often something that is traveling around in a bloodstream. We have a retrograde bacterial infection, which would be where the bacteria are able to ascend a structure like a duct to go from an opening or a larger area to more finer areas within a structure. And we have a fulminant bacterial infection, which would be a severe, rapid, and acute infection. The equation of infections is one of several predictive tools that can be used in disease control to calculate the interactions between an agent, a host, and the environment to determine the probability of the infection, with quantitative values assigned to each of these factors. The equation looks at the size of the toxic dose that must be transmitted to a host, the host's site of contact with the toxic agent, the time of contact, the degree of virulence of the agent, which would be the fundamental element of a microorganism that permits the infection, and all defenses that are taken by the host to block the invasion, to produce an estimate of how probable an infection will be. A microorganism must possess certain genetic properties for survival. It must have defenses against the environmental hazards that would threaten its life. It must have the capability for reproducing itself and the ability to compete with enemies who are intent on their own survival. It must remain viable until it has made sufficient contact with a host to bring about infection, and its survival and effectiveness are dependent upon how it's programmed to achieve these goals. A hit-and-run virus evades destruction by jumping from host to host, while a hit-and-stay virus survives through programming for sequestration, blockading antigens, evading natural killer cells, escaping from apoptosis, and undergoing antigenic change. Everyone will contract some kind of infection at some time, but various factors will alleviate the probability at any point. Some of these factors would be the exposure. Now, with exposure for most diseases, it'd be the brief exposure to a pathogen is all that's needed for an infection to develop. There's the sufficiency, which is the quantity and strength of the pathogen that's necessary to cause an infection, and that'll vary with the nature of the agent and the characteristics of the host. There's the setting, such as in a hospital. There's a mild exposure might be enough to cause an infection, as the patient is probably already in a weakened state since they're in the hospital. Plus, hospitals are full of sick people with plenty of disease agents to go around. There is the risk factor. So, for example, if a woman were to have a greater risk of developing kidney infection, in part because of their anatomy, that would be a higher risk factor. The next section is covering contamination. Now, contamination is an invasion of pathogenic microorganisms into a tissue, such as the surgical site, or onto the surface of the skin of a host, or an inanimate article, such as surgical instruments or doorknobs, or substances like foods or liquids, but in fewer numbers than an infection, so that there are usually insufficient numbers to cause serious compromise of tissue, although contamination can result in infection. Contamination of food products with E. coli have caused major outbreaks of infection, so contamination can be very dangerous, and much of infection control much of infection control efforts are aimed at reducing the contamination of an environment in order to prevent the transmission and the number of infections. A wound that is simply contaminated with a pathogenic microorganism may heal without a serious problem, but if the microorganism were to replicate and invade the tissue, the subsequent tissue damage may interfere with the overall healing process. Contamination can have different meanings depending upon its context. If there is some sort of a contamination of a water supply, it may, for example, have a pollutant in a water supply that would be described as a contaminant. It might be offensive or damaging to the environment and damaging to human beings, but if it's something that is not too concerning for necessarily causing disease, or if it's not infectious, then the epidemiologist might not consider this to be a contaminant of concern. In epidemiology, a contaminant is any extraneous material, usually a microorganism, that has the capacity to render anything infectious. This includes inanimate or animate articles, and therefore could be a source for transmission of infection. The next section covers transmission and virulence. Transmission can often be evaded by the host if the skin is intact and the mucosa is healthy. Normal flora usually remains in balance unless disease or medications affect the immune system. Pathogenic microorganisms, however, have developed numerous strategies to invade a host. Some spores can withstand long periods in an environment and are resistant to heat and drying. Some organisms thrive on the skin and can easily spread to wounds. Some can survive well in contaminated fluids. Others thrive in conditions of poor hygiene. So there's a lot of different ways for them to survive. An incision, rashes, tubes, or trauma that compromises the integrity of the skin or the mucous membrane would facilitate easy transmission. Virulence is the degree of pathogenicity, the ability to cause infection in the host. When comparing organisms, virulence is often evaluated in terms of the infectious over effective dose, sometimes written down as say ID50 over ED50. That would likely cause an infection in 50% of those exposed, or the lethal dose written as LD50. That would cause death in 50% of those exposed. The virulence factors which allow the microorganism to invade a host and multiply vary from one microorganism to another, with some having much more virulent properties than others because of their inherent characteristics. Some of those characteristics are adherence. Some bacteria are more readily able to adhere to mucosal surfaces, such as those that develop fimbriae that facilitate adherence, making them more able to colonize and multiply. Invasiveness. Some bacteria have chemical components on their surfaces, either in the plasmids or the chromosomes, which would facilitate easier invasion of host cells. The structure. Some bacteria are encapsulated, effectively protecting them from phagocytosis or destruction. Toxins. Many bacteria produce lipopolysaccharides, proteins, or enzyme toxins like endotoxins or exotoxins that are extremely poisonous to the host and can cause severe systemic reactions, acute infections, sepsis, shock, or death. And iron binding factors, siderophores. Some bacteria are actually able to use the host's supply of iron to multiply and grow. They use that for competing with the host and facilitating an easier infection. The next section is covering patient exposure to communicable disease. Patient exposure to communicable disease can be difficult to assess, as the person may not be aware of exposure or may be reluctant to discuss it because of privacy issues. That is something that I am very aware of working in public health. Doing a careful and thorough history and physical assessment can provide information that suggests exposure. Questioning people about symptoms rather than their diseases may elicit more information. An example would be, have you had contact with anyone with a rash? Or have you experienced any night sweats? An exposure to a communicable disease can occur outside of a hospital as well as inside. An exposure to communicable diseases can be endogenous or self-infection, or exogenous, which would be cross-infection. Endogenous would, for example, can result from normal body flora or an area of infection such as a boil, which has become contaminated and would contaminate something like a surgical wound. An exogenous infection can occur by contact with someone who is already infected, such as another patient or a staff member, or by airborne particles, and both types could easily occur in a hospital setting. Rate of occurrence. There are a number of ways of measuring a disease's rate of occurrence. Some of these would be the incidence, the rate at which new cases occur in a population during a specified period. The prevalence, proportion of a population that has the disease at a point in time, a measure that is appropriate only for relatively stable conditions, unsuitable for acute disorders. The point prevalence, that's based on a single examination done at one point in time. It tends to underestimate a condition's total frequency. Period prevalence, the proportion of a population that makes up cases at any time within a stated period. This is a better measure than point prevalence when repeated or continuous assessments of the same individuals are possible. And then mortality rate. This, like the other measures, can be combined as when, for example, each new case is put into a prevalence pool and remains there until either recovery or death. The next section is covering carrier case and index case definitions. So a carrier would be anyone carrying a pathogen which could be transmitted to a human being, regardless of whether that person is infected or not, whether the first person is infected or not, or whether they show signs of the disease or not. They are a carrier. A carrier need not be a human being. The disease may be carried by an animal that's unaffected by it. In the Black Plague of the Middle Ages, rats were carriers because they were infested with fleas that were carrying the bubonic bacillus without being affected by it. And for that matter, even the fleas themselves were carriers. The next term, case, is in an epidemiological sense. It's a case is a person who has been infected by a disease in question at the time and in that place. So it's kind of an unusual basic definition. So for an index case, that's a little bit better of a term. Depending on the context, an index case could be the first instance of a disease, like a first case in a disease epidemic. It would be, in that case, the cause of the epidemic. Someone whose phenotype leads back to a study of the family for that characteristic. The first case to become known in a population, or the earliest documented case of a disease that is included in an epidemiological study. These would be index cases. The next set of terms is bias, virulence, direct transmission, and indirect transmission. So for bias, that is an error in the design or execution of a study that will generally produce a bias that skews and distorts the results because non-random factors have been introduced. Though bias happens in randomized controlled trials, it's more common to observational studies. Virulence is a word with its root in the Latin word for poison. Virulence indicates the ability of a microorganism to cause disease. Because the word may also be used as a measure of a pathogen's ability to do damage, it is not entirely synonymous with pathogenicity. Only a small portion of the total population of microorganisms are virulent. Direct transmission. A disease may spread through direct transmission, a physical contact between a host and its victim. Indirect transmission. Disease may also be spread through indirect contact of a victim with an agent by way of something like airborne particles or vectors or contaminated object. The next section is microbial growth in food. Microorganisms of importance in foods require these nutrients: water, energy, carbon or nitrogen, vitamins, and minerals. Most of them require a pH that is neutral, though yeasts and molds can tolerate more acid than bacteria, and a moisture content that has a maximum tolerated, a minimum acceptable, and a point that is ideal for growth. Bacteria prefer the content to be on the higher side than yeasts and molds, which prefer low moisture. Bacterial growth and growth of microorganisms in food. This section covers the 4 phases of bacterial growth. The first phase is the lag phase, the time for microorganisms to become accustomed to their new environment. There is a little to no growth during the lag phase. The next is the log phase. Bacteria logarithmic or exponential growth begins. The rate of multiplication is most rapid and constant. The next stage is stationary phase. The rate of multiplication slows down due to the lack of nutrients and the buildup of toxins. At this time, bacteria are constantly dying, so the numbers actually remain constant. And the last phase is death phase. This is where cell numbers decrease as the growth stops and existing cells die off. There is also intrinsic factors affecting the survival and growth of microorganisms that are in food. These are the level of nutrients, the level of moisture, the pH levels, the amount of oxygen, the biological structures, and the content of any antimicrobials. There are specific needs of microorganisms. Types of microorganisms have specific needs for different levels of oxygen for their growth and survival. Some of these include for obligate aerobes, they require O2. For facultative, they grow with or without oxygen. For microaerophilic, they prefer very low levels of oxygen. For aerotolerant anaerobes, they grow with or without oxygen. For obligate anaerobes, oxygen is lethal. Certain biological structures in plants and animals provide physical barriers to microorganisms. These would include things that are obvious like skin, the rinds of fruit, feathers on birds, bark on trees. Many foods have some sort of antimicrobial factors that protect them against colonization. Milk, for example, has several non-immunological proteins which inhibit the growth and metabolism of many microorganisms. These are things like lactoperoxidase, lactoferrin, lysozyme, and xanthine. Now on to defining a reservoir. A reservoir is anywhere then an infection. A reservoir is anywhere that an infectious disease agent can take up residence and be safe from its enemies. It's a friendly habitat in which the agent can live and grow and multiply before it can move on to infect a new host. Whatever proves welcoming to the agent, whether it's human, animal, plant, soil, or a substance, may serve as a reservoir, harboring the infectious agent and sometimes with little to no injury to itself. Even a host can serve as a reservoir if it can somehow transfer the agent to another host. Primary reservoirs in healthcare run from medical workers to patients to operational units like a food service. And one of the things that we see currently is emerging diseases like CPCRE. You might see that in like small critical care units being kind of harbored in a small unit and being spread from patient to patient. Some medical instruments like dialysis units, catheters, reservoirs can harbor agents, and infections from these instruments usually appear rather quickly, and late onset of infection from devices are rare. However, a case of Staph aureus was reported in a patient 7 years after the use of a particular reservoir. So keep your mind open to the potential dangers. Now to human disease carriers. Hosts infected by the transmittable agents are reservoirs, and they come in different types. There are non-apparent carriers, which carry and transmit an agent while they themselves remain free of the disease. These can include incubatory carriers, who can carry and transmit an agent before they themselves contract the disease. There's also convalescent carriers. They can carry and transmit the agent for some time after they themselves have recovered from the disease. A convalescent carrier who can transmit the agent for more than a year is described as a chronic carrier. There's also zoonoses, which are agents carried by non-human animal vertebrates that can pass a certain microbe on to humans. The next section covers the incubation period. The incubation period is the time between infection with a virus or bacteria to the appearance of symptoms. This can range from as short as minutes to as long as decades. Agents have incubation periods specific to them. For example, 1 to 3 days for cholera, 14 to 21 days for rubella, and so on. Although it can vary somewhat depending upon the dose or the host's immunity for their age, a period can still provide a diagnostician with clues to make the diagnosis. I, in my daily job, working in communicable diseases for public health, use this information for assisting with trying to diagnose a potential outbreak. So if an outbreak has a limited amount of days, to kind of say a period between when someone was exposed to an agent to when a certain symptom like diarrhea starts, we're able to narrow it down to a limited selection of either, contaminants or bacteria or viruses that may have caused a particular illness. Now, there is a period between the acquisition of an agent and the agent then beginning its activity, a period during which the host is in a state of good health in relation to the infection. This is called the latent period, which takes place just prior to the incubation period. When the agent does become infectious, the incubation period usually begins. This can vary depending on the condition. One tool of descriptive epidemiology analysis of an incubation period is quite important because it provides means for not only identifying a disease, but also the microorganism that's causing it and the mechanisms of its spread. Predictions may then be made in preparation for possible spread of the disease, both at the present point and into the immediate future. The incubation period is expressed as an average and by its minimum and maximum lengths. Determining an incubation period is useful in an epidemic with a common source for determining how long antibiotic therapy should be continued in suspected cases, for estimating how fast intervention must be launched in future outbreaks, and for estimating the probable number of deaths that may occur in the absence of any public health interventions. The next section is the period of communicability and susceptibility. That period during which an infectious agent can pass, either directly or indirectly, from a source to a victim is the period of communicability. And it is necessarily an average because the period varies by disease. While pertussis, for example, may be highly communicable in its early catarrhal stage. I know I'm pronouncing that incorrectly. Cathardal. I'm pretty sure it's cathardal, something like that. Anyway, and into the beginning of its paroxysmal stage. This is true only for the first 2 or 3 weeks before communicability gradually decreases and the danger becomes negligible after 3 weeks. When a disease requires that a pathogen be present in the blood or another tissue of an intermediary before passage onto the host, the period of communicability for that intermediating vector must also be noted. For plague, fleas that provide the reservoir for the agent may remain infective for months under suitable conditions. The pneumonic plague they cause, therefore, may be highly communicable, but only under appropriate sanitary and climate conditions and housing situations. The periods of communicability also is referred to as periods of infectivity. There are times after invasion of a host by a pathogenic organism during which the infectious agent can be transmitted, either directly or indirectly, to another host. Periods of communicability vary considerably, sometimes encompassing the time of incubation as well as the active infection. With some types of infections, such as measles, the communicability is higher during the incubation period than during the active disease. The periods of communicability may be continuous, as with HIV infection, or intermittent. The communicability or infectivity may depend upon sufficient numbers of pathogenic organisms within the blood or the tissue of the host. Susceptibility relates to a host having or lacking resistance to a particular pathogenic microorganism so that the invasion results in an infectious process or disease. Susceptibility rates may vary considerably, even among the same type of hosts, depending upon such things as the time, the environment, and the state of the host's immune system. During the period preceding the contracting of a disease, the relative ease or difficulty of contracting a particular infection under given conditions varies from person to person because of the differences in health, age, gender, and many other variables. And this is known as susceptibility. One thing that is true of susceptibility for everyone is a host susceptible to infection is one who lacks sufficient immunity to overcome the infecting agent. Some people may be susceptible to one agent, but still resist infection more successfully to others. Genetic factors may help explain why. Rare gene disruptions cause fatal vulnerability to specific microbes, even though subtle differences, which are more common, arise from minor variations in many genes. Recently developed medical advances now allow the immune system to be monitored like other organ functions, opening new approaches for therapeutic intervention. Next section is zoonoses. The World Health Organization defines zoonoses as diseases, the agents of which are animal vertebrates and are naturally transmitted between these vertebrates and humans. Some would define them as diseases whose agents are shared in nature with other vertebrate species. Direct zoonoses, such as leptospirosis and anthrax, may be perpetuated in nature by single vertebrate species. Cyclozoonoses include those vertebrate animals in which the host requires two different animals to complete its life cycle. For example, the influenza virus is commonly passed from birds to pigs to humans. Metazoonoses are those diseases in which a biological agent multiplies, develops, or both in an invertebrate host before transmission to another or to a vertebrate host. So that is changing from an invertebrate host to a vertebrate host. For zoonotic diseases, here we have changes elsewhere in the environment that will bring on a zoonotic disease. Such change is likely to be produced by climate or changes in land use patterns, like in farming. These impact reservoir distribution, and in chain reaction fashion, they produce changes in animal behavior and population size. For one instance, changes in ambient temperature and rainfall patterns will affect population of bacteria and parasites. You can have drought that may affect vegetation and affect populations of rodents that would carry the hantavirus. Climate change also produces changes in human behavior that encourage the emergence of diseases. An increase in warm, sunny days in the Pacific Northwest can lead to more days of hiking and camping. That could raise the probabilities of contact between a reservoir of an agent and their potential hosts. Creating maps combining the agent survival characteristics with the climate variables enables some degree of risk of surveillance, of risk surveillance. The next section is metazoonoses and saprozoonoses. Metazoonose is a type of disease wherein an agent multiplies, develops, or does both within an invertebrate host before being transmitted to a vertebrate host. The emergence of a metazoonotic disease where there was not one before may occur through changes in possibly the distribution of a vector, the numbers or hosts or reservoirs, or their distribution and size or behavior. Global warming will likely result in a redistribution of such vectors, as larval mosquitoes that thrive anywhere there is sufficient warmth for them to develop can spread out to more locations. Saprozoonoses transmit infections through non-animal reservoirs such as food plants, soil, or other organic material. Deforestation and agricultural activities affect their spread, but they can be tracked easily through conventional environmental monitoring and GIS mapping techniques. They are not too difficult to control. The next section is the probability of diseases being transmitted or passed from animals to humans. Now, several factors may influence the transmission, and some of them would be the route of transmission, the length of the animal's incubation period, the stability of the agent, the population density of the animals in the colony, the husbandry practices, the vector control over the wild insects or rodents, the virulence of the agent, and the length of time that the animal is infective. Some standout things here would be that's been brought up to me in my work before during presentations is, say, husbandry practices. Sometimes, we in America would see warning signs that if you were to buy chickens to keep at your own property, never let them inside the house to live. But that's not always the case as far as what's normal around the world. If you were to go to China, where we see a lot of influenzas go from birds to humans, there is often places where you'll see small farms that have humans and animals living under the same roof. It makes sense for them because they're conserving energy and warmth by having just one room or one roof to kind of conserve everything. But in America, we prioritize the health risk. So that's, obviously not a concern in some third world countries. The next section is the signs and symptoms of infections. So these would be signs and symptoms of infection in patients that should be assessed continually in these circumstances. Common infections involve the wound or the surgical site, the lungs, urinary system, etc. So particular attention should be paid to these areas. Assessment will vary according to the diagnosis. Some standout areas here would be if it's a wound or a surgical site, it should be checked and evaluated for things that would let you believe that there's an infection there, such as erythema, edema, drainage, discharge, that sort of thing. Another thing would be systemic indications of an infection. These could be an increase in temperature or changes in vital signs that should stand out as unusual. So they should be monitored regularly. Another section would be lungs. So lungs should be evaluated by a spirometer as well as auscultation. Very common practice in the U.S. after any surgery where a patient's been put out is to be given a spirometer and asked to use it, 10 times in a row every hour to make sure that their lungs are in good working order. They could cough or have shortness of breath, might have sputum production. These are all things where you might notice that something is going wrong with their lungs and should be something brought to attention. Another thing would be urine. Urine should be monitored for the amount that's being produced, the color and consistency, and if the patient has any burning or dysuria, then that should be evaluated as well. If the patient's having discomfort in the bladder area, flank pain, lower back pain, that could also indicate an infection. Maybe something has traveled up from the urethra to the bladder, up from the bladder, from the ureters to the kidneys. Ensuring adequate fluid intake and monitoring intake and output can help to prevent urinary infections, but getting accurate numbers is always a struggle in the hospital setting. The next section is covering cell-mediated and humoral immunity. Response to the passage of pathogens into the body can meet with two types of defenses. The first is humoral immunity. In the Middle Ages, it was believed that the body was composed of various fluids or humors. The word remains in use in medicine in reference to fluids in the body because of this. And because the antibody-mediated immunity consists of antibodies dissolved in blood, lymph fluids, and other body fluids, this form of immunity is also called humoral immunity. The other mode of attack is cell-mediated immunity, in which the T cells bind to antigens and mark them for destruction by the lymphocytes and leukocytes. When a cell or substance is described as having immunogenicity, it means that the properties that allow it to become an immune response to an infection. It means that it has properties that allow it to provide an immune response to an infection. The word is also used when describing the degree of immune response that can be provided in a host. The next section is factors that make a host susceptible to infection. So infection is a product of exposure. Many factors can influence this exposure. Some of these would be a potential host's proximity to the reservoir or the agent, an agent's degree of virulence, which is its ability to cause an infection, and intrinsic host factors like the state of the health, the sex of the individual, the race, or the such immunity factors as prior exposure to the agent. For example, an infection called chorioamnionitis occurs in 0.5 exposure. In 0.5 exposure to the, in 0.5% to 10% of births, sometimes resulting in cerebral palsy. Intrinsic risk factors that could predispose women to the infection might include the genetic makeup of their immune response or stronger bacteria in their genital tracts. Extrinsic host factors, which include contact with infected medical devices, immunization, access to first aid, high risk behaviors, and being required to come into frequent contact with disease carriers. The next section is epidemiological biomarkers. A biomarker is a measurable event occurring in a biological system, such as that is represented by the human body. In epidemiology, a biomarker is not a diagnostic test, but an indicator that an event has occurred that could later lead to a clinical disease. There are three kinds of biological markers: markers of exposure or dose, markers of effect, and markers of susceptibility. Biomarkers of exposure or dose record an exposure to a toxic agent, but markers of effect record exposure and response. Markers of susceptibility might be identifying characteristics of persons at increased risk for developing a disease. The next section is hand washing. All patients are considered potentially infectious, so hand washing must be done before and after every direct contact with a patient or when removing gloves. Contamination of the hands is one of the most common causes of person-to-person transmission of an infection, and all medical personnel must be trained in hand washing techniques and observed regularly for compliance. Hand washing is done under running water with plain soap rather than antimicrobial soap because of its issues related to resistance development. Hands must be lathered thoroughly, covering all areas of the hands and wrists with soap, and then rinsed. After hand washing, care should be taken to avoid contact with surfaces that might serve as vectors. These surfaces would include things like the faucet handles or doorknobs. The faucet should be turned off by using the elbow or upper forearm or by holding a piece of paper towel as a barrier. Hands should be dried using disposable towels. The next section is laboratory testing. Getting answers with a high probability of being accurate is the best that can be hoped for in a medical test. A test can produce two kinds of errors, though. A false positive result, meaning that the presence of the disease is detected when in actuality there's no disease, or a false negative result indicating that no disease is present when there actually is. Working in public health and heavily relying on laboratory testing, I have seen both of these things frequently. Now, 2 points here are test sensitivity. The sensitivity measures the screening test's ability to correctly identify the presence of a disease. It is the ratio of tests with positive outcomes in relation to the total number of affected, which would be the true positive. So that's sensitivity, and test specificity is the measurement of a screening test's ability to correctly identify the absence of a disease. A test with both high sensitivity and high specificity can be expected to have a high predictive value. Key points here would be a true positive, where the test is positive and the patient has acquired a disease. A false positive, the test is positive but the patient does not have the disease. A true negative, a test is negative and the patient does not have the disease. A false negative, where the test is negative and the patient does have the disease. Now, the level of sensitivity in testing is sometimes a probability of a positive test result when a patient has a disease written as a ratio of TP over TP plus FN. These abbreviations are like TP for true positive, FN for false negative. And there's a degree of specificity, which is true negative over true negative plus false positive. There's also positive predictive value, which is true positive over true positive plus false positive, and a negative predictive value, which is true negative over true negative plus false negative. I don't know if these ratios or if these calculations are going to be on the test, but it would be good to look all of them up. The next section goes into gram staining. Now, gram stain, I guess, would be named after the Danish bacteriologist who devised it in 1882. The gram stain is almost always the first test performed for the identification of a bacteria. Both crystal violet and methylene blue are equally effective for staining microorganisms that can commonly be classified as gram-positive or gram-non-negative. Others that are not stained by crystal violet are referred to as gram-negative and appear red. Other organisms are gram-non-reactive, either staining poorly or not at all. Others are gram-variable, staining in an uneven fashion. A gram stain begins with mounting and fixing a specimen on a slide. The specimen is then stained as part of a 4-part process that uses dyes to stain a gram-positive bacteria, purple, and a gram-negative bacteria, pink. The process must be done correctly, or the results can give false positives or negatives. The slide is examined microscopically for white blood cells and bacteria that would indicate an infection. The size, shape, and color stain of the bacteria also help to identify it. Gram stains can be done very quickly, usually within an hour. And one reason that gram stains are done prior to a culture is to determine if the specimen is contaminated. For example, if epithelial skin cells are present in a sputum culture or in a sputum specimen, then the specimen may be rejected for culture, meaning that it was contaminated. Gram stains during the culture procedure should use young cultures of less than 18 hours, as older cultures of some gram-positive bacteria may give the appearance of gram-negative organisms. Other staining methods are available to visualize components that might otherwise be too difficult to see under a light microscope, used to reveal other microorganisms not readily visualized by the gram stain, such as mycobacteria, rickettsia, spirochetes, and others. The next section covers the Zeal-Nielsen acid-fast stain. Acid-fast bacteria, a type of bacteria that will stain gram-positive, retain the Zeal-Nielsen acid-fast stain's bright red color as a result of the components of their cell walls being thick and composed of approximately 60% lipid and less of the peptidoglycan than other organisms. Probably butchered that, but the stain is used to detect tuberculosis-causing and leprosy-causing organisms from the genus of Mycobacterium. A variety of microorganisms comprise the group known as non-fermentative gram-negative bacilli, with their reservoirs of infection being aquatic environments, including several commonly found in medical facilities. These bacteria include Pseudomonas species, Stenotrophomonas, Acinetobacter, Burkholdia, Flavobacterium, and Acromobacter species. Differing greatly in their levels of virulence, all are resistant to the usual antibiotics. As a result, the non-fermentative gram-negative bacteria represent important healthcare-associated infections and pathogens. The next section covers complete blood count. The complete blood count with differential and platelet or thrombocyte count provides information about the blood and other body systems and is an important part of the diagnosis of an infectious process. The red blood cell or erythrocyte counts and concentrations may vary with anemia, hemorrhage, or various disorders, but are not usually an indicator of an infection. Platelets may increase from a normal of 150,000 to 400,000 to over 1 million during an acute infection. while blood cells, or white blood cells, or also called leukocytes, count is an important indicator of a bacterial and viral infection. An increase in WBCs, white blood cells, above the 10,000 marker, which is usually the normal ceiling, is a typical sign of an acute infection, with the amount of the increase related to the severity of the infection, the age of the person, and the amount of resistance. WBC is reported as the total number of all white blood cells. A normal white blood cell range for an adult is usually somewhere around 4,800 to 10,000. An acute infection will usually be above 10,000 up to, say, around 30,000. But a viral infection would be sometimes 4,000 and below. One interesting thing looking at WBCs is the differences, not just WBCs, but in other lab values, especially when it comes to things like meningitis. If you look at the way that the WBCs, the proteins, the glucose, everything is very different between fungal infections, bacterial infections, viral infections. You can use sometimes someone's lab results to kind of give you a blueprint to follow of what type of an infection you should be looking for. The next section covers differential values. The differential provides the percentage of each different type of leukocyte. An increase in the white blood cell count is usually related to an increase in one type, and often an increase in an immature neutrophil known as bands, referred to as a shift to the left. An increase is described according to the type of cell with the primary increase. So a primary increase in lymphocytes is lymphocytosis. Before computerized reports, when laboratory slips were written out by hand, the practice was to write the values for the differential from left to right in this order. The order being bands, which are those immature neutrophils, segs, which are mature segmented neutrophils, eosinophils, basophils, lymphocytes, and monocytes. So the shift to the left would mean increase in those, the bands, the immature neutrophils, or that sort of a reference. Now, when one value increases, another would usually decrease. When you have an infection, the percentage of bands, the first one being on the left of that list, often increases, thus resulting in the shift to the left. Because the percentage of bands increases, the percentage of the segmented neutrophils decreases. The differential report for eosinophils, basophils, lymphocytes, and monocytes are expressed as a percentage of the total white blood cell count. The normal for eosinophils is 0 to 3%. Some things to note for eosinophils is that if you see an increase that's greater than 5%, you could see that with an allergic response or a parasitic disease. If you see a decrease in eosinophils, you could have that due to bodily stress or an acute infection. Other factors that affect the results: eosinophil counts are lowest in the morning, with rates rising until after midnight. So a repeat test should be done at the same time each day. Stress-inducing burns, surgery, or labor can decrease the counts. Some drugs, including steroids, epinephrine, and thyroxine, can affect the levels. And increases or decreases in basophils, monocytes, and lymphocytes also affect the rates of the eosinophils. Normal basophil levels are 0 to 1%. Things to note here are an increase in the basophil percentage could be seen with blood histamine issues or an infection. A decrease in the basophil levels might be during an acute stage of an infection. The normal lymphocyte percentage is 25 to 40%. An increase might be seen with some viral and bacterial infections, such as tuberculosis. And a decrease in the lymphocytes would be seen with some things like AIDS. The normal percentage for monocytes is 3 to 7%. An increase during the recovery stage of an acute infection might be noted. So it might go higher than 3 to 7% for an acute infection, recovery stage of an acute infection. The differential report for each type of white blood cell, bands and segs, is expressed as a percentage of the total white blood cell count, or leukocyte count. So you could have the bands normally at 1 to 3%, and the bands would, potentially have some fluctuation. So if you see an increase without leukocytosis, but with a massive infection, that's probably not a good thing. The prognosis is usually poor. The reason because the immature cells are overwhelming the blood. There's just not enough mature white blood cells to be effective. If you see an increase with leukocytosis and with an infection, there's sometimes a regenerative shift. The prognosis there is good. So the takeaway for that is when it comes to bands, if you have either an increase with leukocytosis or without leukocytosis, that could help steer your detective work on the severity of the infection as well as the type of prognosis. Now, the segs normally for an adult would be 50 to 62%. You could see an increase with an acute localized or a systemic bacterial infection. You could see a decrease with an acute bacterial infection, which would be from a poor prognosis, and some viral infections. And factors that also can affect this would be stress, exercise, obstetric labor, steroids, short term, as long as you're taking the steroids either short term or for a longer period, that can affect the neutrophils for up to 24 hours. And you can have an increase or decrease in the eosinophils that can affect the percentage rate of the neutrophils. The next section covers MRIs, which are magnetic resonance imaging machines, and also endoscopic procedures. So for MRIs, they may be done with or without contrast. The machine uses radio waves and magnetic fields to create images of an internal structure, providing information about infections that may not be obvious with just an X-ray or a CT or an ultrasound. It is especially helpful for assessing infection of the abdomen and pelvis areas. MRIs are more expensive than X-rays, CTs, or ultrasounds, so they are often done after other testing has been inconclusive. Now, endoscopic procedures use a flexible endoscope inserted through the mouth for the esophagus, stomach, and small intestine, or through the anus for the rectum and colon, through the vagina for the vagina itself, or the cervix, and the uterus, or through the urethra for the urethra itself, for the bladder, or the ureters. They are used to visualize the internal structures, such as the lining of the GI tract and the urinary tract. Endoscopes are equipped with small clippers that can allow for biopsies of tissue so that it can be evaluated for an infection. Endoscopes pose the risk of spreading infection, especially if they are not properly disinfected. The next section covers X-rays, ultrasounds, and CT scans. X-rays are commonly used to detect infections in the lungs. Chest X-rays show areas of consolidation that are often indicative of an infection with purulent material present, such as in pneumonia, especially in those with a cough and fever, to indicate that a chest X-ray would be necessary. Ultrasounds are especially helpful for the evaluation of cellulitis of soft tissue to determine if there is an abscess that may not be clinically evident. And CT scans may be done with fluoroscopy or contrast material such as iodine dye to evaluate for infections. CT scans can differentiate between cellulitis and formation of abscesses better than a routine X-ray. Chest scans can evaluate the organs and tissues of the chest for an infection. Abdominal scans can detect abscesses and infection, and urinary tract scans can detect infection of the kidney or bladder. A CT scan can also be used to determine the best insertion point for a needle into an abscess to affect the best drainage. The next section covers needle aspirations and tissue biopsies. Needle aspirations, which may be completed with ultrasound or CT, as far as guidance goes, are done to aspirate the serous or purulent material to relieve pressure or to take out a culture for evaluation to see what type of an infection is present. Needle aspirations are less invasive than a biopsy and may be used with puncture wounds where there's a little surface area and you want to have little tissue loss. Multiple samples may be needed, so you can usually change position with, say, if it's in a joint capsule, to get different samples. Fine needle aspiration may be used to biopsy infected tissue as well. Biopsy of infected tissue may be done under local anesthetic with a small amount of tissue excised to be examined microscopically, tested, and cultured. Some antiseptics like ethyl alcohol might kill the bacteria and affect the actual cultures that you're hoping to do. Biopsies may be done because a visual inspection alone may not always be as effective in determining if the infection is present, as the infection may be present even without the classic signs of an infection, such as erythema and swelling. The next section covers cultures. Cultures in which a sample is grown on a nutrient-rich media may be done with oxygen for aerobic, or without oxygen, which would be anaerobic, as indicated or ordered by the physician. After the organism is cultured, sensitivity tests are usually completed to determine which anti-infective agents are most successful in treating the particular pathogen. A gram stain is usually done initially, and then the culture is checked every 24 hours for colonization. Colonies are checked again with the gram stains, then also transferred to a separate media
for further observation and testing. Cultures are usually negative if there's no growth in 48 to 72 hours, unless there's a very slow-growing bacteria or fungus, which may need 4 to 6 weeks before the final test results are available. Something like that would be tuberculosis. If antibiotics are begun prior to taking the sample for culture, this can also alter the results, making it very difficult to isolate the infective agent. It can hide that, or it can skew the results. So it's advised to obtain the culture first, then begin your antibiotics. Sputum cultures are done to determine if there is a bacterium or fungus infection of the lungs or respiratory passages. Sterile specimen containers must be used, and people must be cautioned to avoid mouthwashes that could have antiseptic properties. It's important to make sure that the specimen is coughed up and it's not just saliva. A sample may be obtained with a bronchoscopy as well. Viruses are frequent causes of respiratory infections, so special viral cultures in which the sputum is mixed in a test tube with specially prepared animal cells are often done, requiring days to weeks for a final culture for those. Various special culture procedures may be done with sputum to isolate ineffective agents. Cultures are not effective diagnostic tools for all types of organisms. For example, pneumocystitis carnii, a common cause of pneumonia in those with a depressed immune system, cannot be isolated and grown in culture and must be identified by a special stain. Blood cultures using a small sample of blood are done to determine if an infection has invaded the bloodstream from the original site of infection, causing an infection to spread. It is also used to determine the type of bacterium or fungus and the sensitivity to an anti-infective agent so that proper treatment can be initiated. In many cases, if an infection is present, treatment may be started before the culture results and then reevaluated and changed as necessary when the sensitivities are complete. It is important that the skin be carefully cleansed so that the sample is not contaminated by microbes on the surface of the skin. Wound swab cultures are done by taking swabs of wound exudate from infected tissue. The swab technique usually results in the smallest sample size so that the ineffective agent may not grow in the culture. That the infective agent may not grow in the culture. It is also easy to contaminate the specimen with normal bacteria, skin flora. Stool cultures are done to detect bacteria or other organisms in the stool resulting from an infection of the GI tract. Stool samples are collected in a sterile container and must not be contaminated by toilet water or other materials such as urine, so stools cannot be retrieved from the toilet. This is a common issue. Stool specimens are often obtained on 3 separate days. Most intestinal infections are the result of bacteria, but fungi and viruses may also be implicated. Stool cultures are important to diagnose Shigella, Salmonella, Campylobacter, Yersinia, as well as Clostridium difficile, or C. diff. C. diff may result from treatment with certain antibiotics. In the case of some bacteria, such as C. diff, stool culture is done to identify the particular toxin that's produced by a bacterium. Fungal infections, such as Candida, may occur in those who are immune suppressed. Additionally, these same patients are also susceptible to infections with viruses, such as cytomegalovirus, so fungal and viral cultures must be done. Urine culture and sensitivities are done to identify infective agents. Results should show fewer than 10,000 organisms per ml of urine. Bacteria found are the result of pathogenic microorganisms or contamination from the skin. Counts higher than 10,000 are considered diagnostic of an infection. Urine is easily contaminated if clean catch procedures are not followed carefully and if people have poor hygiene. Urine may be too dilute for accurate culture if patients have a large fluid intake. Urine left at room temperature may also begin to grow organisms so the results are possibly not accurate if that's the case. Urine should be not refrigerated for more than 2 hours before it's tested. Urine intended for testing for the cytomegalovirus must not be refrigerated. Urinary cultures are positive for urine infection if the organism is found on gram stain and if 2 urine cultures isolate the same organism with greater than 102 colonies per ml of urine in catheterized specimens or in less than 105 colonies per ml of urine with patients receiving appropriate antibiotics.